Welcome to blackdoctor.org. I'm your host, Shamika Rhymes. Remember to share this with your network because you never know who may need this information that we are discussing tonight. November is Alzheimer's Awareness Month, and tonight's show is all about helping our community better understand Alzheimer's disease. And so we're going to be talking about what it looks like in the brain, how it affects families, and what we can do to support loved ones and caregivers. And this is part 2 of our Alzheimer's series. So if you missed part 1 from November 6th, make sure you go back and check that one out as well. Now let's meet our guests for tonight. We have a great panel of experts. Let's bring them on up. Welcome. How are you?
Wonderful. Thank you for having us.
Yes.
Well, I'm going to let you both introduce yourselves. Dr. Curtis, I'll start with you.
Hello, everyone. I'm Dr. Sansa Curtis, the CEO and founder of 3D Wellness, and I have a brick and mortar outside of suburb of Atlanta, Georgia. And my specialty is functional medicine and preventing and lifestyle medicine.
Thank you. Dr. Golnaz.
Hi, I'm Golnaz Yadullahi Khalis. I'm a behavioral neurologist at Cedars-Sinai. I'm also an associate director of the fellowship program there. So I'm mainly seeing patients with degenerative disorders.
Well, I want to thank you both for taking the time out to join us for such an important topic. So let's kick this off with, for those that may not fully understand, what exactly happens in the brain when someone develops Alzheimer's disease? Dr. Golnaz.
Yes, absolutely. So in terms of the degenerative disorders, neurodegenerative disorders as the whole concept, when we're talking about that, we're talking about abnormal proteins, like the pathophysiology or the cause for almost all degenerative disorders in the brain is abnormal protein accumulation. In the setting of Alzheimer's, the abnormal proteins are two different types. One is called amyloid, AMYLOID, and the other one is tau, which is TAU protein. So what happens is, from what we know so far, I mean, it might turn out to be wrong in the future, but from what we know now, amyloid starts accumulating in the brain about 20 years prior to the onset of the symptoms. So first, people start accumulating amyloid in their brain. They might not have any symptoms. They might not even know they have amyloid in their brain. As time goes by, a group of these people start developing tau in their brain. And because of that, they start losing some brain cells, brain tissue, and that's when we see the symptoms. And the whole process, again, might take about 20 years.
Wow. Well, are there any, with that 20-year span, are there any early symptoms or changes beyond memory loss that families should start to pay attention to?
Yeah, great question. So, we now know there is, because in the past we thought that people start having cognitive changes at the time when they have tau pathology in their brain, and that's when we call it mild cognitive impairment, when people do not have any functional problems, so they are still independent with all activities of daily living. They can still shop, drive, manage their medications and appointments. But now we know there is a concept which we call subjective cognitive impairment, meaning people start noticing a change in themselves. They know that their memory is not the same as how it was before, but we are not seeing it when we test them. On our testing, even sometimes we do a full neuropsych evaluation, which takes about 4 hours, and we're not seeing any deficit on those testing. But then that's when the patients are seeing the changes, and we think that's probably at the very, very early stages. And then, and that's, we know the group of those patients actually turn into mild cognitive impairment. That's when we are actually seeing a deficit on the testing. So yes, we do see some changes in some patients.
Okay. And Dr. Curtis, you and I talked a little bit about some changes. Can you also weigh in here on what changes maybe you've seen in your patients?
One is loss of smell. That's usually an early one there. And also uncontrolled, diabetes, because from the functional medicine perspective, we look at Alzheimer's as diabetes type 3. So when you have an accumulation of glucose in the brain, that also accelerates the folding of those proteins, and it kind of really chokes off the communication. So it's I don't know if you remember having those old telephone wires, and then they start severing little by little. And so you start to see a little bit of change there. Irritability is one where they just get frustrated. They can't do regular daily tasks and they get upset about and can't remember words. But sometimes menopause is the same thing. So sometimes you know what's going on. So that's kind of usually what I see. They just get frustrated because they can't perform just regular daily activities, or can't recall a name, or simple, like it's an apple. I know it's an apple, but I can't really, it's red, it's a fruit, and it's, that type of thing. So you can see that early on.
Thank you. Dr. Golnaz, how important is early diagnosis, and what types of screenings or tests are available to detect Alzheimer's?
Mm-hmm. So the reason, maybe 20, 30 years ago, it didn't really matter to diagnose these disorders early on, just because we did not have any treatment options. Now we do have some treatment options, and they are only available to patients at the early stages of the disease. So that's why the early diagnosis is very important. And we now know there's a difference in terms of the prognosis of the different types of degenerative disorders. So that kind of also informs us about how the disease is going to progress. So a patient with Alzheimer's disease might progress differently from someone who has, let's say, dementia with Lewy bodies. Mm-hmm. So from both a prognosis perspective and treatment perspective, it's very important to diagnose patients at the early stages of the disease. The tests we do when patients come to our clinic, the history is the main thing. So that's very, very important because we might not see everything on the testing. And the history we take from the families, mainly people or caregivers, people who are seeing patients on day-to-day basis, is very important. Then we do an examination, a neurological exam, because some of those disorders may show a change in patients' neurological exam. For example, they might show Parkinsonian features. They might show a change in their walking. So that kind of helps us as well in diagnosing or differentiating between these different disorders. Then we also take into consideration the past medical history. As Dr. Curtis mentioned, it's very important to ask about the vascular risk factors, such as high blood pressure, diabetes, high cholesterol, sleep apnea, which goes actually undiagnosed in a huge number of patients. Mm-hmm. And then the family history is very important, as we know, although these disorders might not be hereditary in a sense that it's not like, for example, if they have it in the family, they 100% are going to get the disease, but that they have an increased risk of having it if there's a family history of, let's say, Alzheimer's disease. So that's also important to know. Then we go over the medications, because some medications can make someone look like they have Alzheimer's disease, or they might actually make symptoms worse if someone already has a degenerative disorder. Then we do a neuropsych evaluation, which is a test to check different aspects of cognition. And when we talk about cognition, we talk not just about memory. We talk about memory, we talk about language function, as Dr. Curtis mentioned, having troubles with finding the right words to say. That's part of the language function. And then we check the visual spatial function, and then we check the executive function, which has to do with planning, with organization, with a lot of actually things that we do on a day-to-day basis. And then we take a look at the brain imaging as well. So we try to put all these pieces of information together to find out what the diagnosis is. And then even with all that, we might be so certain as to what the diagnosis is. There are now biomarkers that can help to diagnose Alzheimer's disease. I'm not sure if you're getting to that later on, or you want me to talk about that now.
Oh, yeah. Please talk about it.
Yeah, so the biomarkers that we do have biomarkers for Alzheimer's. And then I'll talk about Lewy body dementia as a separate entity. But then about Alzheimer's disease, there are three types of tests that we can do to help us diagnose Alzheimer's disease. None of them are perfect. So we rely a lot on them to say someone has Alzheimer's or not. But then again, they have very good sensitivity and specificity. It gets very close to 100%. But again, there are patients who actually do not show a positive biomarker, or did not have a positive biomarker, but they still have the disease. So there is that group as well, but that's a very small group. So one of the tests is a PET scan of the brain, and that PET scan checks for amyloid inside the brain. It does not check for tau. It only checks for amyloid. So that's one of the tests that we can do to help us diagnose Alzheimer's disease. The other test is a spinal tap. So we go in the back, we get the fluid that goes around the brain, around the spinal cord. The test is like similar to epidural type testing. And then we check the fluid for both proteins, for amyloid and tau. So in a sense, spinal tap is more comprehensive as opposed to this amyloid PET, but then obviously it's more invasive. The other one, which is newer, is a blood test. And the blood test, the old blood test, which was checking the amyloid ratio, does not confirm the diagnosis. It only shows whether someone is at risk of developing Alzheimer's disease. The newer test, which is p-tau217, is kind of confirming the diagnosis of Alzheimer's disease. The reason why I'm saying kind of is because it's not as accurate as the spinal tap and the amyloid PET. Most clinics or most labs, when they check that and if it comes back high, it says in the bottom that you have to confirm it with either of the other two tests. So it's a good kind of a screening test because it's easier than the other two. But then still, if it comes back positive, we have to get the other testing to confirm the diagnosis. About the dementia with Lewy bodies, there are two tests that we can do to help us diagnose, but they are not as accurate as the test that we have for Alzheimer's disease, unfortunately. One is the skin biopsy. So for the dementia with Lewy bodies, as the name tells you, it's the accumulation of Lewy bodies in the protein. So it's similar to Alzheimer's, where there is amyloid and tau. In dementia with Lewy bodies is Lewy bodies, which are the abnormal proteins that accumulate in the brain. And we know it's like a kind of a systemic disorder. So we might see these abnormal proteins in the skin as well. So that's why the skin biopsy can help. But the problem with the skin biopsy is obviously we cannot take samples from all our skin. So we just choose sites to take the sample. And it might be the case that the place where we take the sample doesn't have alpha-synuclein or the Lewy body in it. So it might come back negative, but that doesn't necessarily mean that someone does not have dementia with Lewy bodies. And the other way to test for it is through the spinal tap. So when we do the spinal tap, in cases where we think they might have dementia with Lewy bodies, we check for both, for Alzheimer's biomarkers and the alpha-synuclein. That one is more accurate than the skin biopsy. But overall, comparing to the Alzheimer's biomarkers, the ones that we have for alpha-synuclein are not as sensitive and specific.
Thank you. Because I was about to ask the difference, but you explained that too. So thank you for that. Dr. Curtis, from a functional medicine standpoint, are there any additional tests and screening that you might do?
She pretty much covered all. Another one is ApoE. We look at for more if you have a family history. So that's for early onset. Well, it's for people that want to work more for the preventive. And so if you have ApoE3, ApoE4, then you have, and you have a family history, then really working on prevention and lifestyle is key. But that's the only additional one.
Okay.
Looking at genetics.
Okay. And I don't know if this also kind of goes with what we just talked about, but Dr. Golnaz, what does current research show about prevention or slowing progression, especially in the Black community?
Great question. So we know the Black community has higher risk of developing Alzheimer's disease. And then when they develop Alzheimer's disease, the symptoms are worse compared to the white community. So definitely prevention is the key, like any other disorders. A recent study came out, which is called Pointer study, which we highly recommend that all our patients actually look at the results of that study. So what they worked on was dividing the people into two groups. They put one group on the structured exercise program and the MIND diet. The other group was also recommended to follow a good diet and also exercising. But the first group was the group who received like regular follow-ups. So are you exercising? Are you like following this diet? And they actually saw an improvement in both groups' cognition during the course of the treatment. Obviously, the group who was in the structured program improved more compared to the other group. But then the results of this study and similar studies in the past show us that exercising, and when we talk about exercising, we talk about like a cardiovascular exercise, something that increases the heart rate. So a lot of patients might be like, well, I'm walking my dog, or I go to a park and walk. Those type of activities don't really count because they might walk and they might stop, or like going to a mall and just like window shopping. That's not like an exercise we're looking for. So something that increases the heart rate for 30 minutes. And I mean, the better, like the more they do, the better it is. But then it does, as long as they do it at minimum 30 minutes a day, it's perfect. And then the other thing is about the diet. The two types of diets that we recommend are MIND diet and DASH diet. Basically, what they include is grains, vegetables, fruits, white meat. And then a combination of that, if like people can make recipe or like can find recipes, including those things, that also works. It doesn't have to be like called MIND diets. That's like the whole concept. The other two things that are important are socialization. So unfortunately, during COVID, we know like a lot of people had to isolate themselves. The other problem is that as people get older, they might lose some of their friends. So staying socially active is very, very important. So being engaged in the community, it could be the faith centers, it could be senior centers. So places where people can go and like be in touch with other people, it's very important. And sometimes people might be like, well, I mean, I do not want to talk with people. That's fine. Even sitting somewhere, like sitting among a group of people, even if you're not participating, that also helps the brain activity. And the other thing is cognitively stimulating games or activities. This might include anything like crossword puzzles, any types of like card games, or it could be like the group activity, like playing chess. It could be dancing. It could be learning a new instrument, or like learning to speak a new language. So all those activities can help a lot in preventing cognitive decline. We now know there is a concept called cognitive reserve, which depends on a lot of factors. And one is being the education level, one being like, for example, how demanding your job was when you were younger. But a lot of it, you actually have a role in by doing all those activities, you can build it. And the way it manifests itself is actually when you look at someone's brain and you see a lot of tissue loss in it, but that person might still be doing very well cognitively. So that tells us there is a good brain reserve there.
Okay. It also brings to mind something my grandfather used to say. He'd always say, make sure you keep your mind active. And, he lived to be 95. So he was still being active and doing things every day, the exercise, all of it. So I think there's something to that. Dr. Curtis, from your perspective as, functional medicine, how do some of the other lifestyle factors such as sleep, environment, even stress and anything else, how does that play a role in Alzheimer's risk?
It plays a huge role because I think we underestimate stress, and stress really increases your cortisol, which increases your insulin. So that increases more glucose to the brain. So I measure just on routine exams, I measure insulin because they've shown if you measure the fasting insulin, and you have insulin resistance, then that's reversible. You can reverse that. But once it goes into diabetes, then you can just stop the progression of that. So I really monitor that. And piggyback is social determinants of health. People of color don't get the same treatment of other people. They get ignored. They think that they're they think that they're pain seekers or they're exaggerating, or that's just, like I said, that's just Miss Nettie. That's how she is. She's been that way all the time. And we just chalk it up as something else. And then you have the distrust in our population of going to the doctors because of the Tuskegee and all of the things. And that shows that we are not on the forefront when it comes to clinical trials.
Mm-hmm.
How many of us people of color, there's genetic differences in how many people of color actually step up to do the clinical trials because they just don't feel comfortable, because they don't trust the system. Mm-hmm. So community is key in this, and faith-based, and walking in. And they showed a study that when a person walks in and see another person of color and they're their provider, whether it's their primary care provider or their neurologist, they have a better outcome because they feel trusted. Mm-hmm. I'll never forget, I walked into a room when I first started seeing patients, and I walked in, and it was an African-American guy. He says, "Oh, I'm so proud of you. You up there with Rosa Parks." And I was like, "Not Rosa Parks." So it's a sign of trust. And the other thing is food deserts. You're in the city. Show me a Whole Foods in inner city. It doesn't exist. You don't have gardens or community gardens. They're starting to develop those more. And we're eating out of processed foods. Processed foods are just toxic to the brain. And it's, all the foods that we're consuming. I always tell my patients, look at your plate. It should be the color of a rainbow. If you eat a whole bunch of grains and starches and different things like that, that's going to affect your brain. And we have brain-derived neurotrophic factor. And as she was saying, it helps. It's like spinach to Popeye, it gives you that strength to the neurotransmitters in the brain. And like I said earlier, 10,000 steps a day decreases your risk factor up to 52% of Alzheimer's and dementia. So just exercising and movement. And 35,000 steps decreases up to 25%. Mm-hmm. So exercise and movement is key. Most of the time we're in the city, we don't exercise, we don't move, and sleep. I did 15 years of sleep apnea, and you really cut off oxygen to the brain, and then you have cardiovascular issues, and it just exacerbates your underlying condition. And then it just sleep, lack of oxygen, you can't think.
Yeah. So was that 3,500 steps or 35,000?
3,500. Did I say 3,500? Yeah. Sorry.
Yeah, I was just making sure.
I got too excited there. 3,500.
I'm like, I get 35,000 in a week.
10,000 steps a day for at least 5 to 6 days a week.
Okay. And this question is for both of you. Let's talk a little bit about caregivers, because I think sometimes caregivers get left out of the conversation because they do a lot of the heavy lifting here. For many families, caregiving begins gradually. What are some of the first steps that caregivers should take once a loved one is diagnosed? Dr. Golnaz.
Great question. Actually, in our clinic, when patients come to see us, we give a questionnaire to the caregivers as well to assess their health and stress level. We now know that although there is a thought that caregivers are more stressed out towards like the end stage of the disease, they are actually more stressed out at the early stages because everything is new to them. They are not used to this disease. They don't know what to do. Any symptom is like new to them and they don't know how to deal with it. So as the disease goes by, they get more used to it. They like find their own like techniques to deal with different behaviors. So what I think is the key for the caregivers is education. So talking about the symptoms, I don't think talking about the prognosis is as important as talking about the process or the path, as the disease gets worse, because we don't know about like the prognosis. We don't know how long it takes from one person to go from one stage of the disease to the other. That we don't know, but we know what symptoms to look out for. Like, for example, we know in some disorders, like people might develop troubles swallowing at the earliest stages of a disease. For example, we know for Alzheimer's, especially when it happens after age 65, the majority of the problem or the biggest problem is memory. So people keep forgetting things. They might repeat themselves over and over again. So teaching techniques, so then the caregivers know how to deal with these behaviors. I think that's the key. And a lot of times we tell the caregivers that the medications are not going to help this. I mean, I cannot think of any medications that can help someone with Alzheimer's stop repeating themselves. They will continue repeating themselves. It's just how to deal with it as they occur. I think that's important. I think one other thing that I recommend, honestly, is to always, the recommendation for the doctors or the primary care physician is always to check in with the caregivers as well. We know, like in some patients, there's this thing called insight. They lose their insight into the disease. They don't know that they have the disease. They think everything is fine with them. They don't have memory problems. They're like the same as before. And the caregivers a lot of times try to convince them, oh no, you have Alzheimer's. You have to accept this. And then the moment they leave the clinic, they forget. So we always have to check in with the caregivers, see how they are doing. As you mentioned, they are the ones who are taking care of these patients. So their well-being is as important as the patients. And we always try to discuss the next steps or the things that need to be taken care of early on, such as, for example, power of attorney, like financial and health power of attorney. That's something that they need to address at the very early stages of a disease when patients still have decision-making capacity. For example, if they want to look into the finances, a lot of patients might have trouble paying their bills. They might forget to pay the bills and stuff like that. So it's important to discuss those things early on. A lot of times, caregivers ask about placement options. I think obviously that's not a thing that might be an issue at the early stages of a disease, but then I think it's a discussion to have with the caregivers as the disease progresses, because they have time to look into the facilities, or if they decide to have placement in the future. I think it's important to look, because then when the time comes and they are in this situation where they have to find a placement in next month, they might not find one. But then if they have a year or two or even 4 years to look into a facility, then they can do it at their own time to find the best facility.
Okay, because some facilities may have a waiting list.
Exactly.
Yeah. Okay. Dr. Curtis, do you have any advice for caregivers once a loved one is diagnosed?
I agree with Dr. That it's just education is key. Mm-hmm. If you don't know the disease and don't know how the progression, even if you might not have that conversation with the person that you're taking care of, you need to be aware of it so you can see those signs. And the biggest thing is not to argue with them. It's mm-hmm. almost this, the more you confront them, sometimes the more agitated they get, and then it just causes conflict. And I totally agree. As far as the finances, it's mm-hmm. my mother-in-law had dementia onset by chemotherapy. And it was quick. 1 month she was driving, the next month she didn't even know where she was living. So that was really kind of for us, it was really, astonishing to kind of watch. And just adding that caregiver to their bank account so they still have some autonomy. Mm-hmm. And then gradually, if they need to, you're there to kind of watch them, but that you're still watching over them at that point. And building community. Our in the African American, it's all about community and respite care. You have to, if you don't take care of yourself, I always tell my patients, you cannot take care of your loved ones. Self-care is essential. So you have to find some respite care, either a neighbor, a cousin, an aunt, or somebody to come in so you can actually have some downtime, so you can be able to be there. I have one patient right now, her mother has Alzheimer's and she's the only child. Mm-hmm. She has caregivers, but she feels she has to be the one to take care of her because that's ingrained in our, as an African-American female and you're taking care of your mom, you feel like that's what you have to do. Mm-hmm. And the other part is not feel guilt, because it's nothing you did or nothing they did, or it's just part of the disease. And, and accept it. And then also, unfortunately, our system is not as cohesive as we would like. So keeping records of everything is key. So when they go to the primary care, they know what they're taking, because sometimes you'll go and they'll give you something else, and it can be contraindicated in the medication. But if you kind of keep up with their records and you have it, I always tell my patients, get a binder and ask for the notes. So when you go to the next, like, oh, I see that you changed this. Well, you know that as a caregiver. So you be on top as a caregiver, be on top of that, their care, just as well as their doctors, because a lot of times we don't communicate in the system. The system, I was in school 30 years ago, so the system used to communicate better, but it doesn't communicate as well as it used to.
Mm-hmm. You brought up a great point about caregivers needing to take care of themselves, and I can't remember exactly what month we did a show here on BlackDoctor.org on Celebration. We had a whole show around caregiver burnout and stress and self-care. So what are some signs of caregiver stress or burnout that doctors and family members should look out for? Dr. Golnaz, I'll start with you.
Yeah, great question. Unfortunately, we see that a lot in our clinics. A lot of times they just feel anxious. They might also show problems with their memory. They might keep forgetting things. I go to a room forgetting why I went there for, type of thing. Or it might also affect their health. They might start like similar things that like someone with like heart disease might show. They might start like getting pains in different parts of their body. They might feel like a chest pain. They might even they are at high risk of actually developing cardiac and brain disease, such as like strokes. So it can be very severe. The signs we see could be psychological, it could be physical symptoms that we see when caregivers are burned out. And the other things is that a lot of times and because of those symptoms, they cannot take care of their loved ones anymore. So they're just they are frustrated every time. They repeat themselves, they get frustrated. They might do something, it takes time for people to get used to the changes in their loved ones. And then sometimes they might forget that they have a disease, they have a dementia, they're not doing it intentionally. And the burnout will add to that. So they might get frustrated very easily, they might get annoyed, and then they might be like, well, I don't know what to do with this. And they might the patients with dementia, they might have a problems with their sleep-wake cycle. So they might be awake at nighttime, they might go to sleep in the morning. And that can affect the caregivers as well. And then the caregivers a lot of times are still working. So it might affect their job performance as well. They might lose their jobs just because they're taking care of someone at home. So having this time off for themselves, as Dr. Curtis mentioned, in terms of having respite care, that can help a lot. And they can have a free mind to take care of their loved ones, and they can provide better care if they are mentally and physically healthy. Because a lot of times, actually, that's when we see that they forget about themselves. They just don't go to the doctors because they're like, well, I cannot leave my spouse at home by themselves, so I cannot go to a doctor. And that way, that kind of makes things worse, because, for example, if they have knee pain, they have to have a surgery done for that, then they are not going to take care of that. So it's it makes things, it's a vicious cycle type thing.
Okay. Dr. Curtis, do you notice any other burnout signs in caregivers that maybe come to your practice?
Yes, I agree with Dr. Golnaz. I mean, because when they don't take care of themselves, before they even state that they may be overwhelmed and they just can't handle it, a lot of times you'll see that they gain weight, or they come in, they're disheveled, they don't take care of themselves. Somebody that used to put makeup on doesn't come in with makeup anymore, or they lost weight and because they're not eating, because they're taking care of them, or they come in, they have dark circles under their eyes. So sometimes you have to just pull them aside and say, what's going on? And then they'll go on and tell you that they are overwhelmed. I think in the African American community, we carry our strength, it's our strength, we're not going to burden anybody else with that. And you have to release that. You have to find either therapy, you have to find support groups, you have to find other ways for you to release that. And again, you find them guilty. They feel guilty that why is mom or dad or husband, trapped inside of this? I don't understand. Or they become hyper village, they come in with all these things and all these studies, and they want to take all these supplements and they want to do all the things. And I'm like, no, I'm not here to take your money, because you're putting your money in that. Dr. David Perlmutter, he wrote this book. Dr. Dale Bredesen, about the brain recode. And so they'll come and they're at, severe, and they want to do this because they think that they can reverse Alzheimer's. Just no. The whole process of that is reducing the inflammation so you can reduce some of the symptom, but you're not going to get your neuroplasticity back. You're not going to get your brain tissue back. That's not going to happen. And so I think they start looking for, I call it the Cinderella syndrome. They look for, it's going to happen overnight. It's going to turn into a pumpkin, and their mom or dad or their loved one is just going to be healed instantaneously if they follow these supplements or follow this regime or follow these medications.
Okay. Dr. Golnaz, how can medical professionals and caregivers work together to create care plans that are both clinically effective while being culturally sensitive?
Great question. I should say it's difficult. A lot of times the doctors are not aware of the cultural differences. So they apply, I'm originally from Iran, so I'm familiar with my own culture. Like, for example, if I see patients from Iran, I know a lot of times the caregivers do not want to discuss the diagnosis with the patient. So they want to discuss it in private, and they do not want the patients to know about the diagnosis or hear the name Alzheimer's disease. Mm-hmm. So I think it's very important to take into account the cultural differences. I think that's very, very important. For example, some people might be okay with placing their loved ones in a facility. The moment they know they have Alzheimer's, they're like, well, they already knew that that's going to be the case. The patients are ready for it. The caregivers are ready for it. So it's like a smooth transition. In a lot of cultures, that's not acceptable. As Dr. Curtis mentioned, they want to take care of them towards the end of the disease. So that's very important to know. We do have, for example, at Cedars, I know there is a program, and I know it's available in a lot of places that have dedicated memory programs. We do have a program called CARES program, and it is called something similar to this in different places. What the purpose of these programs is to actually meet with the caregivers and discuss the resources, discuss the behavioral modifications, discuss the symptoms that they are seeing in the patients, and the strategies to deal with these behaviors. So, and these symptoms and the needs will change. So it's not a thing that, I have this meeting today and then it's going to be taken care of and I'm good for the next 10 years. Each day there might be a new symptoms. It might be the case that we talk about something and that might not be applicable to every single patient that we see in the clinic. It might be the case for one caregiver, but the other caregiver might not have this issue. We know patients with dementia can show different symptoms. A group of patients might be very apathetic. They are amotivated. They want to just sit at home, do not want to be engaged in anything. There is another group of patients who are actually agitated. They might get aggressive. So knowing the differences, knowing how to discuss these things with the family members. The other thing that's very important is to know what the caregiver's point of view is in terms of the medications. Mm-hmm. We do see patients in the clinic where the caregivers are like, do you know of any medication that can help this? We're fine with just giving the medications. We just want to take care of these agitation and the behavioral changes because we cannot take any more of that. There is, however, another group of patients and caregivers who do not want any treatment options or pharmaceutical or pharmacological options whatsoever. They want to try other like non-pharmacological options, such as like behavioral, like distraction, or like, for example, we always say, find like an activity. So if they keep repeating themselves, you can tell them, oh, let's go out for a walk, for example. So that takes their mind away from what they were fixated on. So things like that, I think it's very important. The other important factor is having a social work person involved in the process early on. So they might know of resources. And it might be like it, and resources doesn't always have to be like placement options. It can be like educational classes for the caregivers. It could be like care centers, like it could be like a day center where the patients might be able to go to and engage with other people. So I think it's a multidisciplinary type effort. So and everyone needs to be involved to be able to take care of like the different aspects of these disorders.
Thank you. Dr. Curtis, you mentioned a little bit ago about community. And so many caregivers in the Black community, they rely heavily on faith and family. So how can healthcare providers honor that while offering some practical support?
I think by just there really needs to be a program for an advocate to make that bridge. And I think a bridge in everything, like Dr. Gomez says, just understanding the different communities and understanding the different culture is what we're not taught in school. So how are you going to bring that in? You're going to bring that in by finding an advocate in that community for somebody to speak for that and bridge that gap by having, talks at churches or mosque or whatever, what community that person or faith that person is, and for them to understand and come at it from their perspective or seeing it from their lens instead of trying to see it from the medical lens. And I love Dr. Gomez. Her eyes are open of just saying, it's people are different, but most of the times when people go to the doctor, they look at you like if you have Alzheimer's, you have this stamp, it's A, B, and C, and you're out of the door. And they're not looking at behavior. They're not even trying to communicate with the family or anything else. And so I think that is key, understanding that community and that community's belief and and their trust factor in all of that, and bridging in and speaking regular language. I love that she was just speaking regular language, to us today and not talking above us. She was actually talking to us. And I think that is key, even with the patient. You're talking to the patient. If the patient's in early, onset, they understand. And a lot of times as African Americans, you feel like, why are you not talking to me? Why is she talking to my daughter and why she's not talking to me? And then that agitates them even more. So actually talking to the patient, building that community, and it goes beyond even the churches. I mean, I've spoken at salons, I've spoken at barbershops. What type of community is life for that particular culture is what we have to break into. And it's really not healthcare, is community wellness, community care. And we have to bridge that gap, because if we don't bridge that gap, we're going to start to lose a lot more trust, and people are not going to get the help early, and people don't even know the signs of what it is. And if we know the signs as a caregiver, as a daughter or a son or a husband or a wife, then I think we would bring our loved ones to Dr. Gomez early and not wait until it becomes, late onset and there's nothing you can do about it.
Absolutely. Are there any new treatments, medications, or research breakthroughs that are giving hope to Alzheimer's patients and their families right now? Hopefully so, Dr. Gomez.
Yes, so we now have 2 FDA-approved medications, which is like a breakthrough in the field. We did not have those medications like 5 years ago. So one came out in 2023 and one in 2024. The purpose of those medications is to take the amyloid outside of the brain and hopefully slow down the progression of the disease. One thing we always emphasize on is they do not reverse the disease process, and they do not improve the disease. They just slow it down, which is, again, a huge deal. I mean, the whole point is to keep the disease at the stage that it is at for now, hopefully for the new medications to come out, so patients will be eligible for those medications in the future. And by keeping the patients at the early stages of the disease, it also preserves their independence, because at the early stages of the disease, people can still do a lot of things on their own. And besides those medications, there are clinical trials that are ongoing. They are working on, because these medications that we now have available, they do have some side effects. They can cause brain bleeds and brain swelling. And the chances, as Dr. Curtis mentioned, will depend on the ApoE status, which is the genetic marker. But the hope is that the newer medications do not have those side effects, or they have very, very low chance of those side effects. And the other hope is that those medications are more effective than the current ones. The most effective one that we have is called the donanemab or Kinsella, which actually slows the progression of the disease by 35%. But with the newer medications, the hope is that they will be more effective in that regard. And there are other, when we talk about clinical trials, they are trying to approach the disease from different perspectives, because we know part of it is the proteins, but part of it could be other factors, like such as inflammation, for example. And there are now clinical trials working on the inflammation part of the disease. We think that might play a role in the development of Alzheimer's. And some medications are to treat the symptoms that we see. And mostly the behavioral changes that we see. But the newer one, or the one that is closer to the finish line, is the medication to address tau, because right now the medications are only working on the amyloid. They're not working on the tau protein. So the newer medications are going to address, or attack the tau protein in the brain. So we'll see if they are as effective or even more effective than the amyloid ones. But yes, there are a lot of clinical trials. One thing I want to mention is about the supplements that are out there, because we always get this question from the patients and the families. None of the supplements that are out there are helpful, or meaning we do not have any evidence that they are helpful to prevent or reverse or slow down the cognitive decline. The ones that we know are helpful are B complex and vitamin D. The other ones that will be advertised for, we don't have any evidence. So if people want to try, they can. We don't even know about the potential side effects. Sometimes the supplements have interactions with the medications that people are taking. So they need to always discuss it with their doctors. But then from dementia perspective or Alzheimer's disease perspective, they are not by evidence helpful.
Thank you for adding that, because I was just thinking, I've heard a few people just in my community talk about different supplements and how they thought maybe it could help, but I'm going to make sure they hear you say that. Thank you for that. So as we wrap up, what's the key message that you would like for our audience to take away about the power of partnership between doctors, patients, and caregivers in the fight against Alzheimer's? Dr. Curtis, I'll start with you.
Like she said, communication is key and community is key. It takes a whole, as I used to say, a village to raise a child. It takes a community to even have wellness and to take care of each other. And I do want to add in, there are doing studies, and they did a study in Japan in 2014, and now in 2024, they have a drug they're doing stem cell and for mild to moderate Alzheimer's, and they're seeing good results with stem cell. And I think it's in phase 2 trials in the US of stem cell. They did it intravenously and intrathecal, where they actually put it in the spinal cord itself. So that is something to look forward to, and it's coming out of Japan. But again, it's knowledge, understanding, and communication. And then for some of the supplements are because that's kind of my world. So the supplements are looking at treating the different types of inflammation, and like the B vitamins and the D and there are some other ones that you can kind of look at to help decrease their blood sugar and different things of that nature. So we're not looking to say we're the disease, but what are some of the things that you may see attached to the disease that you can reduce that will help the progression of the disease. So, when I hear that, even when I looked at the Dale Bredesen protocol, I was like, they were saying that it can reverse. And I'm like, I've never seen that before, but there are some things that you definitely can do to help with that. So again, it's community education and looking into what, like the churches, the barbershops, the salon, and we have to build that trust, and we have to have more practitioners that look like our patients, because that is a big factor in just their recovery or their healing or their demise as well.
Mm-hmm. Thank you for that. Dr. Golnaz, what's the key message you'd like our audience to take away?
So I agree with Dr. Curtis. I think education is the key, and education is not only for the patients and the caregivers. I think education is also for the doctors, for them to know about the differences in different cultures, in the prevalence of different disorders. It doesn't always have to be Alzheimer's. It could be any disorder, like the trajectory in terms of like how patients progress when they have these degenerative disorders, what needs they have when they develop this disorder. So I think the education goes both ways. I think my key message is for patients and the caregivers, or like even for general population, not to be afraid of addressing the memory problems or going to a doctor if they think they have a memory problem. It doesn't always have to be, well, I mean, what if, like, let's say I have Alzheimer's disease, then, I mean, I'm not going to get those treatments. I mean, they have side effects, so why bother to know? I think it's always, we know knowledge is power. So if you know that you have a disease, there are always newer medications and newer studies, or at least so you can do something about it, as opposed to saying, well, I mean, it's probably just aging. So I think, and not being afraid to go to a doctor for this, as if like you're going to a doctor to check for breast cancer, to check for lung cancer. So it's similar to that. So it's like a screening for your cognition. So I think that's a message that I want to put out there. And I think, and it's difficult, as Dr. Curtis mentioned, we need to go to different communities, improve or increase awareness about these disorders, so then people know that there's a difference between normal aging and dementia, so they're not the same thing. And it is an effort from the provider's side. I mean, we cannot like force patients to come to the doctors. We have to go there. That's what we always talk about among ourselves. Yeah.
I want to thank you both for such a great conversation and for sharing your expertise tonight and helping us better understand how Alzheimer's affects our families and our loved ones, and especially, shining that light on caregivers as well. So thank you so much for taking the time out of your busy schedule to come and chat with me and our viewers. And again, this is Alzheimer's Awareness Month, and we truly appreciate the work that you're doing in our communities. So thank you.
Thank you for having us.
Thank you. And for anyone watching, if you've missed any part of tonight's discussion or you want to revisit part 1, again, that was from November 6th. Please feel free to check that out. And you can also find more articles and resources about Alzheimer's on blackdoctor.org. And again, thank you so much for watching, and I hope everyone has a wonderful evening.
Thank you.